I'm now going to carry out a respiratory examination, so I'm going to ask my patient to take a deep breath in and out for me. I'm going to be inspecting the anterior shape of the chest for symmetry. I can't see any signs of barrel chest, which would be a round barrel-shaped chest, which could suggest COPD or emphysema or maybe asthma. I can't see any signs of funnel chest, where the sternum would be depressed. There's also no signs of pigeon chest, which is actually the outward projection of the chest. There's also no signs of flail chest, which is kind of a seesaw movement of breathing. I can also see no visible scarring, which would be there if they maybe had open heart surgery or maybe a pacemaker. I'm now going to look at the patient's pattern of breathing. So I'm going to take their respiratory rate. So can you just breathe normally for me, please? So you can see this patient's respiratory rate is about 16 breaths per minute. There's a normal rhythm and the depth seems to be normal as well. They're not making a considerable effort to breathe. I can't hear any signs of stridor or wheeze. With males and children, they breathe abdominally or diaphragmatically, whereas females breathe intercostally. Being a female child, they are breathing abdominally or diaphragmatically. I can't see any signs of rapid breathing, which would be tachyapnea. This would suggest maybe they had an excess of carbon dioxide in the body or too much oxygen. There's also no signs of hyperapnea, which would be rapid deep breathing. I also can't see any signs of Cheyne-Stokes breathing. I'm now going to measure the chest expansion, both manually and using a tape measure. So to do this manually, I'm going to place my thumbs on the rib cage and my hands around the rib cage. And can you take a deep breath in for me, please? As you can see, my thumbs moved apart. It was symmetrical, so that is fine. I'm now going to do it with a tape measure. So I put my tape measure around the chest. Which is easier said than done. Okay. I'm measuring that. And I'm going to ask you to take a deep breath in for me, please. Okay. And that showed an expansion of 5 centimetres, which is normal. Reduced expansion could be as a result of maybe a collapsed lung or possibly pneumonia. I'm now going to palpate the trachea to check the midline position. I'm going to use my index finger and middle finger either side of the trachea, trying to determine whether the distance between the trachea and the sternocleidomastoid muscles is equal on both sides. The trachea can deviate in chronic conditions or if there's possibly masses on maybe an enlarged thyroid. It could indicate pleural effusion or maybe pneumothorax. I'm now going to palpate for tracheal tug, so I'm just going to check for tracheal tug and by placing my 2 fingers in the suprasternal notch. I'm going to ask you to swallow for me if that's okay. Thank you. So this was normal, however in respiratory distress you'd feel a downward pull of the trachea, so the cricoid would come and hit your 2 fingers. This is mostly seen in children with a chest infection. I'm now going to palpate the anterior chest for any nodes, lumps and tenderness. So I'm just going to place my hands on your chest if that's okay. So I'm feeling for any tender areas, which would indicate any fractured ribs, any masses, which would possibly be sinus tracts, or any tender pectoral muscles, which would possibly indicate costochondritis, which would be like pulled pectoral muscles if they've been lifting heavy objects. I'm now going to check tactile vocal fremitus anteriorly. I'm going to use an ulnar border of my little finger to compare each side of the chest as I move down the chest. Each time I place my hand on your chest, can you please say 99 for me?
99, 99, 99, 99, 99, 99.
Vibration was slight and not marked and decreased as I moved down the chest, which was normal. If it was strong, then the patient has increased a vocal tactile fremitus, which could be possibly consolidation, lobular pneumonia, or thick mucus. If it was weaker, it would be decreased tactile vocal fremitus, which would be caused by fluid or air causing the vibration to be lost, which could be potentially pleural effusion or pneumothorax. I'm now going to percuss the clavicles for resonance. So I'm going to tap on the clavicles on the lateral, middle and medial areas, comparing each side as I go. I'm listening for a resonant sound. A dull sound could indicate a mass. I'm now going to percuss the anterior chest symmetrically for resonance. The aim of this is to determine whether the underlying lung tissue is air-filled, fluid-filled or solid. So I'm going to use my middle finger to percuss down the chest, comparing each side. The lungs are normally resonant to percussion. A dullness could indicate lobar pneumonia. A stony dull sound could be a large pleural effusion, or hyperresonance could indicate emphysema or pneumothorax. I'm now going to auscultate an anterior chest symmetrically for resonance. Every time I place the stethoscope over your chest, are you able to breathe in deeply for me, please? The breath sounds were soft and low pitched, which suggests normal vesicular breathing. If I'd heard much louder, higher pitched sounds, that would suggest bronchial breath sounds, which could be because of the air-filled lungs being replaced by solid tissue or maybe fluid. I didn't hear any sounds of crackling, wheezing or a pleural rub. I'm now going to auscultate the chest symmetrically for vocal resonance, so they're going to be speaking. If you're able to say 99 every time I touch the stethoscope to your chest, please.
"99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
The sounds were muffled and they diminished as I moved down the chest, which is normal. If they'd been clear sounds and loud, then that could have suggested a solid mass in the lungs or potentially lobar pneumonia. I'm now going to auscultate the anterior chest symmetrically for vocal resonance, again, but this time murmured. So if you're able to whisper 99 this time, every time I place the stethoscope against your chest.
99, 99, 99, 99, 99, 99, 99.
These sounds were faint and could hardly hear them at all. If they'd been clear or loud, it could suggest pneumonia. Just from looking at the patient's back, I can see that there is no obvious deformities, it's symmetrical, there's no signs of scoliosis, kyphosis or kyphoscoliosis. I'm now going to measure the chest expansion again posteriorly. I'm going to do this again by placing my hands around the ribcage with my thumbs apart, and ask the patient to breathe in deeply for me, please. As you can see, I think my thumbs moved apart evenly. Reduced chest expansion could suggest a collapsed lung or pneumonia. I'm now going to palpate the posterior chest using the flat of my hand for any lumps or tenderness. So I'm just going to touch your back, okay? Any tender areas could indicate fractured ribs. Lumps could indicate potential masses. I'm now going to check tactile vocal parameters posteriorly. This is done the same way as anteriorly. I'm going to use the ulnar border of my little finger. If you could please say 99 every time I touch my hand to your back.
99, 99, 99, 99, 99, 99, 99, 99.
I'm now going to percuss the posterior chest symmetrically for resonance. Any dull sounds could suggest that there's a solid mass in the lungs. Hyperresonance often accompanies emphysema or pneumothorax. I'm now going to auscultate the posterior chest symmetrically for breath sounds. So every time I place a stethoscope on your back, could you breathe in deeply for me, please? I heard soft, slow-pitched sounds which suggest normal vesicular breathing. If it had been louder and high-pitched, that could have been bronchial breathing. There's also no sign of crackling or wheezes. I'm now going to auscultate the posterior chest again, symmetrically, but for vocal resonance this time. So if you could please say 99 this time, every time I place the stethoscope on your back.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
The sounds were muffled and indistinct and became more distant as I moved down the back. Loud sounds would have suggested pneumonia. I'm going to do the same again, auscultating the posterior back for resonance, but asking the patient to whisper 99 this time as I touch the stethoscope to their back.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Again, the sounds were muffled and indistinct. I'm now going to percuss posteriorly for diaphragmatic excursion bilaterally. So I'm going to first ask the patient to breathe out deeply and hold it for me, please. I'm going to percuss down the back until the sound turns dull, which happens here. I'm now going to remember this point and ask the patient to breathe in deeply and hold it for me. I'm going to go from here, percussing downwards until it turns dull again, which happens here. The measurement here is about 4 centimetres, and we'd expect it to be between 3 and 5 centimetres. If it had been smaller than this, it could suggest a pneumothorax. I'm going to repeat this now on the other side. It turns dull around here. I'm going to ask them to breathe in now. Again, that is about 3 or 4 centimetres, so that is normal. That is the end of the respiratory exam. This patient showed normal respiration.